I have just started this open meeting in compliance with CMS guidelines. For the record, prior to doing so, I announced that Palmetto GBA would make an audio recording of the open meeting. Palmetto GBA only recognizes the Teams webinar recording that will be posted on the Palmetto GBA website as the accurate and reliable record of the meeting. I would like to take this time now briefly to just make sure that the speakers please adhere to the 15-minute allowed time interval that they have for their presentation in order to keep things on time, in order to keep things rolling in continuity with our prescribed guidelines. With that being said, on our agenda, the first presenter is Dr. Kraus, and Dr. Kraus, you can go ahead and begin. Thank you.
Hi, how are you? Thank you very much for having me. Can you hear me okay?
Yes, sir, I can, or we can.
Okay, and I believe that you guys are going to be putting up the PowerPoint and moving the slides. Is that correct? Perfect. Okay.
Yes, sir, that's correct.
Okay, great. Well, my name is Dr. Ira Kraus, and I am the CAC rep for the Tennessee Podiatric Medical Association, representing the podiatric physicians who practice in the state of Tennessee. As a side note, I am a past national president of the American Podiatric Medical Association, and I'm currently also the AMA CPT advisor for APMA to the CPT meetings. So obviously, there's a new LCD that has come about, and we have some comments and concerns with regards to the nerve blocks and LCD that's been promoted. So if you want to switch to slide 2. Yeah, thank you. I think that it's pretty obvious that the 21st Century CARES Act established clear expectations on how federal health policy should integrate with real-world evidence. And I think that when the MACs are developing these LCDs, those same principles should apply. I think if you review the current policy, it should be rooted in science and real-world evidence. And we ask that the determinations align with the intent of the 21st Century CARES Act to use the best available real-world evidence to guide fair and patient-centered policy. Slide number 3. When we talk about corticosteroid injections that could be used in the treatment of neuromas, it's something that was used and has been used for many, many years. I found it to be a very efficacious treatment plan for my patients. I found it to be something that I used almost immediately when patients came in for conservative care, along with a variety of offloading and other different things. But I definitely think that if you the LCD does acknowledge that corticosteroid injections are accepted. And so we recognize that the steroid injections are covered, but we want to make sure that medically necessary service aligns with both the clinical practice and the scientific evidence, because as we go further, we'll see that there's really no scientific evidence that promotes or discusses a limitation on or a cap on the amount of injections that are received, but more based on patients' clinical findings. Next slide, please. When you look at probably the next couple of slides 4 and 5, they talk about the evidence with the standard of care. There's the discussion that there's multiple systemic reviews in clinical studies that have been reviewed. The studies collectively are showing that steroid injections are efficacious and can definitely be used to relieve pain and improve function. The question is that the LCD's inclusion of the corticosteroids as a covered treatment is scientifically justified. I guess the real question here that we all need to think about is whether the proposed lifetime limit on these injections is equally supported by the evidence, which, as we'll show next, it is really not present at this point right now. So you may want to go to just jump to slide 5 for me. And you'll see that the review that was done by Thompson and his colleagues is one of the sources that's quoted in the LCD. Not to quote everything in the article, but I think the takeaway here is the corticosteroid injections were well supported by the literature, while the proposed 2 injections per lifetime per side limit is not. The LCD proposal goes beyond what the science supports and restricts physicians' ability to tailor care for individual patients. We are physicians. We should be making decisions based on medical necessity and the way the patients present and how they respond to certain treatment plans. I would hate to have to tell a patient that they're getting better, but I have to stop because Medicare says there's a limit on the amount of procedures that I can provide to make them feel better. We can probably go on to slide number 6. I think again, when you look at these different articles, and I think slides 6 through 10 are going to show you a variety of different articles that have been reviewed and studied, and I think that the overall message that's coming out from me on slides 6 through 10 that I would like to convey is that the literature supports the use of corticosteroid injections, but it provides no scientific justification for a rigid utilization cap as two injections per lifetime. When you look at all of the articles and literature that's cited on slides 6 through 10. And I'm not going to go through all of the different slides because I think that it would not be an appropriate good use of time. I think that this is something that you can all look at, but I can tell you that all of these slides, all of these case presentations that we've presented shows that. I would probably jump ahead to slide 11 at this point, where we have a maximum of 2 steroids from Morton's and Aroma may be administered per lifetime per side with references provided. None of these provide data to support this lifetime limit. If you look at a review of these papers, none of them establish or even suggest a lifetime maximum number of corticosteroid injections for Morton's and Aroma. Instead, these studies consistently note wide variation in injection protocols, some using 1 injection, others 2 or more, really depending on the patient response and the duration and the follow-up duration. For me, again, clinically, this made a huge difference for my patients. It was a game changer from the standpoint of avoiding doing a surgical intervention. Periodically, patients needed to have the injection. It might have been an episode of care that was a very short period of time for me, but sometimes the patients might come back 6 months or 12 months later and have a recurrence because of an activity that they performed. But again, I think the message here overall is that the proposed limit is not supported by the MAC's own citations. So the articles that you have even given as a reference are underscoring the need for a policy that aligns with real-world evidence and clinical discretion. I am going to ask you to jump to slide number 14, the exclusion of therapeutic posterior tibial nerve block for tarsal tunnel. The proposed LCD explicitly lists the posterior tibial nerve block at the tarsal tunnel among procedures considered not reasonable and necessary for chronic pain. I think that this is a blanket exclusion grouped with unrelated procedures, such as occipital, pudendal, and genicular nerve blocks with no scientific rationale or citation. By categorically denying the coverage, the LCD is removing a clinically validated low-risk treatment option that could provide pain relief and delay surgery in patients. The exclusion conflicts with the LCD's own stated reliance on reasonable and necessary standards, and with CMS's expectation that coverage determinations be evidence-based, patient-centered, and flexible to clinical judgment. I think that when you look at this from a real world practice, patients do very well with 1 to 2 injections per year, sometimes less, for years, avoiding surgery and higher risk care. And I think that's really the goal, is to be able to provide good conservative care for patients that will help them alleviate their pain and discomfort and be able to have a normal functioning lifestyle. If we go to slides 15 and 16, there is science and real world evidence to support the medical necessity of posterior therapeutic nerve blocks for tarsal tunnel. There's peer-reviewed literature to support medical necessity of therapeutic and posterior nerve blocks at the tarsal tunnel. I think that you will see that the evidence quality is mixed but consistent in direction, and coverage should be criteria-based, not categorically excluded. I think that you will also see that there have been articles that talk about success stories. We have multiple sources that have been listed for you to review. I think the literature supports a measured criteria-based approach rather than your categorical discussion. I think that we need to look at the patient as individuals. And I think, again, when you consider the fact that when these patients have pain, a lot of it could be caused, at least in my experience, biomechanically. And I think there are a multitude of different things that we need to look at for the patient, whether they need to be biomechanically controlled with an orthotic, whether we need a corticosteroid injection to help resolve the acute inflammation that is developed in conjunction with possibly stretching exercises or medication. But without a doubt, having the ability to provide these injections is definitely something that is beneficial for our patients. So, I mean, if you look at slide 17 and 18, we talk about steroid injection can be an effective conservative treatment option for patients with tarsal tunnel syndrome. As you can see, there's been a variety of different studies and articles that have been done. The statistics vary in the percentage of patients that did not require surgery that were receiving this. It definitely shows that there's real-world evidence that supports inclusion, not exclusion, of therapeutic posterior nerve blocks for the tarsal tunnel, for treatment of tarsal tunnel in the LCD. I think rather than CMS or Palmetto using a categorical denial, coverage really needs to be criteria-based. I think incorporating evidence would bring the LCD into alignment with the 21st Century CARES Act and CMS's commitment to science-driven and patient-centered policy. I think that you can continue to look at some of the other slides, and you can see 19 through 22 has a variety of different studies that you can look at that talk about favorable outcomes with tarsal tunnel, including the use of steroid injections. And I think that if I were to ask you anything for my profession and anybody that is treating, any clinical qualified healthcare provider who's treating these conditions, I have 3 asks. I ask that you maintain coverage for the corticosteroid injections from Morton's Aroma. I ask that you remove the lifetime cap as it is not supported by science or real world evidence. And I ask that you consider and review all the literature that's been submitted on therapeutic posterior nerve blocks for the treatment of tarsal tunnel, and consider including this as a treatment, as a covered indication under clinical criteria in the LCD policy. Hopefully I've completed everything in a timely manner and provided you with all the information for my colleagues in the podiatric medicine and surgery space.
Thank you, Dr. Kraus. So we're going to move on to our next presenter, Dr. Kaplan. Go ahead.
Hi, this is actually Dr. Cohan. Dr. Kaplan is not speaking. I am speaking. So thank you first, everyone, for having us and giving us the opportunity to speak. I'm a physician at the University of Virginia, middle of doing procedures right now. And so can you go to the second slide, please? We just really wanted to take the time to talk about this very important care for genicular nerve denervation for our patients. We're going to go over first on the slide, it's showing kind of some of the aspects of which we felt are limitations of the current LCD evidence analysis. I'm going to start with the inappropriate grouping of techniques. And I think that this is really important just to have some background and really understanding why this matters. And so pulsed RF compared to thermal are very, very different modalities. Pulse does not make a lesion. And anyone that's a practicing interventional pain physician like myself is not going to be using pulsed RF as a standard of care when performing this procedure. There's differences not only in the fact that it does not make a lesion, it's more neuromodular in nature, but in the way it delivers the energy all of this is very, very, very different. And so studies that are combining this are really not grouping like techniques and not really following what would be known in the standard of care in clinical practice. And then kind of come back to some of these other points as we're going through the slides, but if you can proceed to the next slide, please. And so why does this matter? It really matters in just why are we doing this, right? We're doing this to help our patients. And I have been practicing before this procedure came along, and we used to get patients referred to the pain clinic for knee pain, right? But the thing is, we haven't had a new drug for knee pain in over 20 years. We had nothing to offer these patients. We did not want to start opioids. They had already potentially had injections. They might have started duloxetine, and there was nothing left for them, right? They were being sent to us. We basically pretty much had to say, I'm sorry, we really don't have anything to offer. But since this procedure came along, it's been seriously life-changing for our patients and us as practitioners, because we finally had something that actually helped people. Numerous stories of patients. An elderly couple who they used to love salsa dancing and had not been salsa dancing in 20 years. And there was no other treatments for her until, we performed this procedure, and, they went out salsa dancing for the first time in 20 years. Another story of a patient, it was elderly sisters, and she had to rely on her sister to push her everywhere in the wheelchair. And after this procedure, when they came back and follow up, time and time again, they joked because they said, they were still going to have this wheelchair, but now I'm giving my sister a break because I'm pushing her around for a change. And so this really, really makes a difference in patients' lives. We have no alternatives. We do not want to go back to opioids. And there's real demonstrated evidence, not just these clinical anecdotes, that this procedure helps people. Next slide, please. So I mentioned, these were anecdotes, but there's a huge body of evidence. So numerous level 1 randomized controlled trials showing longevity of the procedure, comparing this procedure to steroid, comparing this procedure to hyaluronic acid. There's been crossover studies. There's been prospective studies. There's been real world retrospective studies, systematic reviews, which we're going to talk about in the upcoming slides, society guidelines, which we're also going to get to in upcoming slides. This body of evidence suggests and proves that RFA really does yield statistically and significant, clinically meaningful improvement in pain and is safe. Next slide, please. So when we get to systematic reviews, we understand that the LCD looked heavily at the Almeida study. This slide is not presenting the Almeida, but we're going to get back to that. But there's a reason why I'm bringing this up. And so the Almeida study, first of all, there was not a single United States author. And so, we're talking about practice in the United States. And so that is one limitation. It also did not include any of the most recent studies, including the study we're going to talk about on the slide. Another thing is that the quality of evidence that the authors themselves stated was poor, right? They basically concluded that they cautioned making determinations based on a poor level of evidence. More importantly, going back to what was one of my first points about different lesions, different techniques, this is extremely important. Right? The studies that were included were very heterogeneous. There was different devices used, and different devices and technology can deliver the lesions differently, like I mentioned. Additionally, there were variables in the lesion patterns. There were variables in the nerve targets. Therefore, you cannot make generalizations when the techniques in order to perform this procedure needs to be sound. You need to have standard techniques that we know work. And when people are doing different techniques, different nerve targets, and lumping these all together, we're not going to have the same results, and that's going to draw down the quality of the evidence. And so it's extremely important to have high quality evidence in order to make your determination. And the authors themselves said, that they weren't saying, that it should be non-covered. There was nothing in their recommendation determining that. They said not routinely used, but what does that mean? We don't routinely do any procedure on any patient, right? We're not doing procedures on every single knee patient that walks through the office. We are picking patients based on their clinical outcomes and criteria. So we're choosing the patients that are most appropriate for this procedure. And that's what's when studies that are done that show correctly chosen patients and correctly performed techniques, they all have universally showed superior outcomes. Taking this as the ketogene, this current study, this is a systematic review out of the University of Utah, which clearly showed a huge number of patients using 11 randomized controlled trials, numerous observational trials. There was significant relief, 50% of patients receiving at least 50% benefit, 6 months, 12 months for osteoarthritis, and even for post-surgical persistent surgical pain. These are huge outcomes in chronic pain. Patients with chronic pain, it's hard to get them better, right? There's lots of multiple factors in their thing, and this is one tool to help them. And so it clearly showed evidence to support that. And again, going back to the lesions being important, the type of lesion, the size of the lesion is really integral. And so this study proved which we already knew, right, is that you need larger lesions. Larger lesions make a difference. So properly performed technique, larger lesions, these really improve outcomes. Next slide, please. Going back then to the societies. The LCD relied on one pain society and many non-pain societies. It's okay to conclude non-pain societies, but those societies were not really specifically looking at genicular, right? They were looking at conservative therapies, which is appropriate because the conservative therapy should be used prior to genicular. But there are, the Aspen study clearly showed level 1, grade A, consensus strong that genicular nerve ablation is safe and effective therapeutic for treating knee pain secondary to OA, and also pain that's refractory to TKA, which is even harder to treat. But yet their analysis showed clearly level 1, grade A, consensus strong. This was underplayed in the LCD. Additionally, RFA of the geniculars can significantly reduce knee pain and improve function in patients with knee osteoarthritis. Again, level 1, grade A, consensus strong. This is really important. They also, going back to that lesion type again, thermal or cooled. It's important to understand that cooled does not mean a non-thermal lesion. It's just a different type of thermal lesion, but these are not pulsed, right? They should be utilized when performing genicular nerve ablation. So again, the type of lesion matters. When you use the proper technique, the proper lesion, you have level 1, grade A evidence. In addition, there's other societies. The Indian Society of Pain, also level 1, grade A, consensus strong. The NICE supports the use of genicular RFA. We're in the midst of publishing a huge multi-society, several multi-society guideline paper, which, I'm one of the authors. This is important. We are coming out with more data. There's numerous data that is still pending that was not incorporated into the LCD. There's the SCOPE trial, which is a huge multinational study. There's also the Congenius study that's ongoing. There are these numerous studies that are providing, that will soon be providing more data. So therefore, it's extremely important to be able to include this information. We ask that you not only really rescind this LCD, but at the very least postpone it. Also a reminder that the reason for medical necessity is essentially safe and effective. There's numerous studies that show this is a safe procedure. There's nothing that has been shown in the literature that shows that it carries significant risks. There's a huge body of literature that shows that this is effective. Again, it truly makes a difference in the lives of our patients. But you can see the numerous references. We don't have time to go over every single practice, but again, it's a huge body of evidence that suggests that this is a safe and effective procedure for patients.
Thank you, Dr. Kaplan. Let's move on to the next speaker, I apologize if I'm saying it wrong, Dr. Guyan.
All right, thank you. Thanks for having me. So we're going to talk today about cryoneurolysis with iovera for pain management for osteoarthritis of the knee. So if you could switch to the next slide. So cryoneurolysis, quickly what it is using iovera. So it's a handheld device that we use to create reversible long-lasting pain nerve block that can last with data up for 90 days. So it's basically the application of cold temperatures with this special device that interrupts nerve signals, creating a grade 2 axonotmesis type injury. And it's really important to note it is a drug-free nerve block that gets long-lasting pain relief. So first, I forgot to introduce myself. I apologize. Clay Gwynn. I'm in Atlanta, Georgia, and I'm a PM&R sports and spine provider physician. So iovera actually was specifically called out by Congress with the No Pain Act that was put in at 2023, lasting from 2024 to 2026. So I think it's really important that we note that. And this is one of many reasons why we should be fighting to maintain coverage for the iovera cryoneurolysis and to allow access to our patients for this treatment, because it is really an important thing that I've seen in my clinical practice that help us avoid dangerous long-term opioid use and as a secondary option or tertiary option when conservative options have not worked. And that's why we're requesting that Palmetto withdraw this proposed LCD, because it would deny coverage for cryoneurolysis and other pain management modalities such as RFA, and that maybe we should start fresh, work in collaboration with clinical societies on policy that has the proper role in both acute and chronic pain management. So we can go to the next slide there. So quickly, just to define, to make sure everyone's on the same page when we're saying this, right? So you just heard a talk about radio frequency, and pulsed radio frequency was mentioned, so we won't dive into that too much, but these are done at high temperatures, 42 greater than 60 to 80 degrees Celsius, and certainly can cause potential damage to anything within the area of ablation. Those are different from cryoablation, which is using the exact opposite of that, cold, extremely cold temperatures at negative 140 degrees Celsius or greater, and also do cause complete destruction of nearby tissue. So what iovera does, this is the device that you see on the left-hand screen there. We have multiple different needles that can be used of varying lengths for both palpation and ultrasound, as well as fluoroscopically guided treatments. And it causes a grade 2 axonotmesis at a temperature of negative 88 degrees Celsius. It's very safe with minimal side effects, maybe some local bruising. So very safe, and we see it used very routinely in our practice and having patients get quick, long-lasting results. If you can move to the next slide. So cryoneurolysis, it's been something that's been mentioned by multiple societies. The Orthopedic Society, they did note that denervation therapies may reduce and improve function in patients with symptomatic knee OA. And really important to highlight that the Radnovich study in 2017, which we'll talk in a little more detail here in a minute, they deemed it as high quality. Also, the Department of Health and Human Services has indicated in regards to cryoneurolysis can be indicated for numerous persistent intractable pain conditions such as trigeminal neuralgia, chest wall or rib pain, phantom limb pain, neuroma type pain, peripheral neuropathy, knee osteoarthritis, and neuropathic pain caused by herpes zoster. As a clinical provider who treats these regularly, these are very hard to treat, and our patients really unfortunately don't have a lot of options. So having an option like cryoneurolysis has really been a game changer to offer these patients something. And additionally, the ASA, the American Society for Anesthesiologists, also recommended that cryoneurolysis may be used for post-thoracotomy pain syndromes, low back pain, treating medial branches, and peripheral nerve pain. You can move on to the next slide. So diving a little bit into the Radnovich study, which the AAOS did indicate as a high-quality study. It was a prospective, randomized, double-blind, sham-controlled, multi-center study with 121 patients that received cryoneurolysis and 59 that did not. Patients that were treated were KL grades 2 and 3 as far as their knee osteoarthritis, with primary endpoints looking at the WOMAC pain scores from baseline to day 30, and then secondary endpoints looking at their visual analog scale and then their total WOMAC throughout the 30, 60, 90, and 120 days. So you can go on to the next one. So with this study, patients in the iovera group demonstrated a statistically significant greater reduction in WOMAC pain score in comparison to the sham groups at all days 30, 60, and 90. While statistical and significance is obviously important, so is the magnitude of clinical improvement. Results of the present studies provide support of the efficacy and support of cryoneurolysis for the treatment of pain and symptoms of NEOA. So, for example, at day 30, the relative magnitude of improvement WOMAC score was at 54% and the VAS at 61%. So I think it's important that we note patients continue to have that relief at 90 days. And these are treatments that we're doing on patients that are getting very painful surgeries like total knee replacements, or are patients that don't have the ability to get a knee surgery and they really are out of options. So options such as radiofrequency or cryoneurolysis are the options that these patients have. And just to highlight things like Dr. Cohen said, but these treatments are things that I've been able to help couples dance for the first time in 20 years. We've been able to help a cancer patient that didn't have an option walk his dog with his wife, which was some of the last things that he wanted to do in his life. So these, every single day, these treatments like cryoneurolysis and others are changing people's lives. So just want to really highlight. So if you want to go on to the next slide. So another really interesting and important thing to mention, the Radnovich study was a high quality study. It was randomized in a controlled setting, but there's also this really unique IGOR data that's certainly currently in draft manuscript, but looking at pain and function scores of people that have been treated with iovera cryoneurolysis at the 12-month mark. So the results from these studies did show that improvements in pain and function with NEOA were really just very effective and more effective than first-line therapies. And you can move on to the next. So hitting from that IGOR data, this 2025 publication, I think it was Mont et al., I do believe. It looked at with a perspective and again, it's perspective, it's multi-center, it's real world data. So IGOR standing for Innovations in Genicular Outcomes Registry Analysis. It compared 6 of the really common non-operative treatments that are used. So things like long-acting steroids, regular steroids, NSAIDs, hyaluronic acid, and then also had cryoneurolysis put in there. So if you, there's a total of 480 patients that were enrolled. The chart on the right shows the proportion of patients who achieved MCID or minimally clinically important difference with these treatment groups. And as you see, the light blue bar indicates a similar proportion of patients treated with cryoneurolysis to the deep genicular nerves achieve pain reductions as with corticosteroids. A higher proportion of those deep cryo patients achieve pain relief as compared also than with NSAIDs and hyaluronic acid. So this IGOR data is real world data to show what cryoneurolysis is doing, along with the Radnovich trial that we're helping our patients in our clinic every single day. So you can move on to the next. So this slide, we won't go into complete detail, but some other studies that really the take-home points are: first, iovera is important. It's evidence-based tool that helps in the multimodal pain relief toolkit that we all have. Sort of, again, piggybacking on what Dr. Cohen said, these patients that we're treating with this, it's not every patient that comes in with knee pain or any of these other types of pain. It's really unfortunate if we don't have the access to these treatments, because we see patients, when you treat chronic pain patients, when you're a physiatrist like myself, a lot of times we see the worst of the worst. We see people that have been told by everyone that they have nothing else that can be done for them. So having things like thermal-based treatments are really a game changer for us, because the last thing that people like myself and every other doctor out there treating pain want to do is say, the only option we have for you is opioids. We've done so much to fight this battle of opioid deaths. We can't at this time not allow our patients, our Medicare patients, to have access to these very validated and just life-changing treatments. So again, it's iovera is evidence-based. It's to help reduce pain. It's to help reduce opioid use. Clinical studies showing outcomes out to 12 weeks. And with the iovera device, with multiple studies, there's so many real-world evaluations that have happened, but there's more and more coming out. Cryoneurolysis is younger, it is newer, sort of in its use and compared to something like a radiofrequency ablation, but it is something that really makes a huge impact both on the acute pain and chronic pain side when we're treating these patients. So you can move on to the next. So despite evidence repeatedly showing cryoneurolysis is effective in managing long-term pain, the proposed LCD would adopt a blanket non-coverage policy for cryoneurolysis and other effective forms of pain relief. This policy would be exactly, like I kind of mentioned, the wrong step to go in this crisis of opioids that we have. Since we have opioid deaths on the decline, it would be detrimental for things like iovera, radiofrequency ablation, and peripheral nerve block coverage to be lost. The Department of Health and Human Services report identifies these non-opioid therapies as important tools in the multimodal management of chronic pain condition. And as a provider who treats these patients daily, I absolutely agree. We certainly all the time are using first-line therapies, and those therapies do work, but it's imperative that we have options that we can treat these patients when they fail surgery, because those are the patients that are coming to our clinic, the knee pain patients that had 2 surgeries and they still have pain, or the cancer patient that's not able to get surgery because of the risks of it, or the too obese patient that needs surgery, but we're trying to help them lose the weight with techniques like this so they can have a more fulfilling life. So the patient access consideration is entirely absent in this proposed LCD. So adopting a blanket non-coverage will really be devastating for our patients, and it will really make it where us pain management providers don't have options except for dangerous opioids to provide to these patients. So you can move on to the last slide there. So in conclusion, to wrap up, iovera is safe, iovera is effective. It's a way we deliver cryoneurolysis at -88 degrees Celsius to have durable pain relief in both the chronic and the acute pain setting. It is an FDA-cleared device for treatment of knee osteoarthritis. There is high-quality data already, and continually there will be, especially with the IGOR data. And it is multiple respected societies, such as the American Academy of Orthopedic Surgeons, the Department of Health and Human Services, and the American Society of Anesthesiology, recognize this iovera cryoneurolysis as a valid treatment. Additionally, one more time, want to highlight that CMS and through passing of the law through Congress, iovera was specifically called out by the No Pain Act. So we really hope and we really urge Palmetto to withdraw these proposed LCDs, reconstruct a policy in collaboration with clinical societies that allow us to best treat our patients in chronic pain. So thank you for your time and your consideration.
Thank you for your presentation. And if we can move on to our last presenter, Dr. Song.
Can everybody hear me okay?
Yeah, go ahead, Dr. Song, please proceed.
Oh, hey, yeah. So thank you everybody for your time. Something near and dear to my heart, prostate cancer in general. One of the reasons I went into urology was to kind of advance care for our patients. A little bit about my background. I'm a private practice physician at Georgia Urology. We're one of the larger groups in the country with 60 practicing urologists. When we add on our APPs, we have over 100 providers. And we've been doing a fair amount of focal prostate cancer when the case calls for it and is the right option for our patients. I did my first IRE procedure for focal ablation in 2024. As a group, we've done over 150 cases. And again, I think one of the things that we've tried to do is we've endeavored to apply this to the patients who really benefit from this. So if you can advance to the next page, why we chose irreversible electroporation as one of our primary means for focal ablation is just because of the mountain of evidence and the application of this very novel but game-changing procedure for our patients, right? So this is something that has FDA indication, that has great outcomes in multiple studies now. It's endorsed by the Society of Urologic Oncology. It's in our AUA guidelines. And it's something that after looking at multiple focal ablation options, both myself and multiple members of our group picked this because of the safety profile and because of the oncologic control that is shown in all this other past data. Next slide. All right, so what are we currently doing for prostate cancer? Next slide. We know that prostate cancer is extremely common, depending on what decade you look at, it's either number 1 or number 2 for most common cancer in men. Rates are on the rise, and this is something that has a significant toll for our patients, both in terms of their mental health, financial liability, their ability to, their quality of life, and how they interact on both a social setting and in the future with their partners, with their loved ones, whether they're able to go out and enjoy their later years, 60, 70, 80. This is something that has a huge impact, right? So right now, the standard of care is, it's black and white, right? So it's on two opposite ends of the spectrum. You either go on active surveillance, where patients are avoiding treatment altogether. They're being watched sometimes for decades. And during that time, there's risk for clinical progression. Oftentimes, these patients are going through multiple biopsies. They're getting annual PSAs, and they're living with this constant, thought in the back of their mind that there's cancer in their prostate. And some of my patients really suffer from that, right? They come to me and they say, "Doc, I'm losing sleep. I'm losing weight just because I'm stressed out. I know that you've told me active surveillance is an option for me, but I just can't proceed with active surveillance on a mental and emotional level." But then on the opposite end of the spectrum, for the patients that we're taking to therapy, we're either taking their entire prostate out and then reconstructing the urinary system, or we're going scorched earth and doing full prostate and sometimes pelvic radiation. And these treatments have significant risk to our patients, both in terms of acute morbidity and mortality, but as well as long-term risk, right? So risk of erectile dysfunction. And I think that's something that, a lot of lay people, don't really consider the impact of these very common side effects from prostate cancer, right? What does it mean for someone to have erectile dysfunction? It's not just that they can't have sexual intercourse. It's they're missing out on one of the major factors of intimacy with their partner. It puts increased stress on their married life. I have multiple partners of my male patients who come and tell me, that they worry that it's them, right? Like, is it something that I'm doing that I'm unable to, have my partner can't get erect around me anymore? And I sometimes have to counsel my patients' partners that, hey, this is not you. This is the cancer, and this is one of the very common side effects of having that. In addition to that, there's incontinence, right? And again, I think this is a word that we throw around. We say, oh, a patient has incontinence, but what does it mean to be someone in your 60s and you can't go out and go for a run without soaking through a Depends, right? What does it mean if you can't go to a ball game and not have to bring a change of underwear or a change of pants because you're going to be leaking if you're out there cheering on your team? This incontinence is something that significantly affects our patients' quality of life. Oftentimes, patients will go through multiple, repeat procedures to try to restore the incontinence. And for some patients, it just doesn't work. Not to mention all of the other risks of these treatments that we don't even have listed here, things like radiation cystitis, injury to the organs during major prostatectomy. Some of my patients who have an enlarged prostate and are not good surgical candidates, they have to pick between radiation, which may limit their future enlarged prostate options, versus going through a much more dangerous surgical option. And so, this is kind of the dichotomy that we have. We either leave the cancer alone, or we put patients through full gland therapy that has major risks and side effect profiles. Next slide, please. And so that's where, I was very excited about the thought of focal prostate cancer treatment. So, even back in 2022, this is something that our AUA guidelines, incorporated into the workup for patients. For the right patient, I can't stress that enough, right? We have to be selective about who we're applying this therapy for. For the right patient with the right intermediate risk, this can be a great option as the in-between method between either the extreme of active surveillance or the extreme of full gland therapy. All right, next slide. There's multiple kind of focal ablation options, right? The great thing about irreversible electroporation is the amount of evidence that it has and the safety profile that it has compared to HIFU and cryotherapy, right? Cryotherapy and HIFU, these are kind of structure agnostic, right? They're both based off of heat in one case, cold off the other. Whereas irreversible electroporation, this is something that will respect some of the boundaries of our organs because of the nature of that of this option. All right, next slide. Bit of a timeline here. In the interest of time, I'm going to skip over this, kind of the history of IRE, but suffice it to say that there is a long history. There is data. This is not something that's, complete unknown. It is a newcomer, but there is a growing mountain of evidence that this is something that's effective. Next slide. And I think that's reflected in the hospitals and the institutions that are embracing it. All the top countries across, top hospitals around the country are offering 14 out of 15 of the top rated hospitals. Majority of the NCCN member institutes. This is something that urologists across the country are seeing the evidence for and seeing the demand for from a patient side as well. Next slide. More data. I think this system, one of the things that made me more comfortable with it is that this has been around the block in Europe and in Australia, and in these other developed nations. This is, in many ways, Europe, Australia are more conservative with what options they offer to their patients. This is something that they've also vetted there, and just because of the timeline of how this option spread, they have even more experience than we have here in the US. And again, a mountain of data, 32 publications, nearly 3,000 patients, kind of vetting this procedure as an option. Next slide. PRESERVE study, this is a US-based study, 17 sites, over 100 patients, and 12-month follow-up. And we'll review some of the data here. Next slide. In PRESERVE, right, this is one of the things that drew me to this as an option. If you look at urinary continence and erectile dysfunction rates compared to kind of the gold therapies of radiation and surgery, this is much, much lower, right? This is something that patients look at and they say, my gosh, I can drop my risk of incontinence from, 20% down to 1% and even less long-term. Just as a safety standpoint, as a adverse effect standpoint, this data is kind of night and day. Next slide. You look at sexual function here, and even compared to other focal ablation options, IRE's got great data to show that there's fewer side effects. And these other options, they're already approved for focal ablation, right? Cryo and HIFU, this is what we're doing for our patients already. IRE, when done correctly and done with multiple probes, it's got an even better safety profile than the already expected modality or already accepted modalities of cryo and HIFU. And then last, this right side of the slide, even more importantly, when you look at IRE, the in-field failure rates, right? Previous slide. The likelihood that you're going to have cancer come back within the treated area is significantly less compared to cryo or HIFU. And again, this goes back to the way that IRE works between those needle pairs. We can cover everything within that field when we're performing IRE in the way that these studies show, right? So I think that's another factor that's important. We have to respect the data and perform IRE in the way that it's been studied using multiple needle pairs. And when we do that, we see that the in-field failure rates are extremely low. Next slide, thank you. Not only that, but it preserves your options in the future, right? So this is something I counsel my patients on. Look, I recognize IRE is new, right? I recognize that there's risk. It's not going to be as definitive as radiation or surgery in some cases, But in those cases, it doesn't close off doors. And for a man who can, avoid prostatectomy for another 5 or 10 years, that's 5 or 10 years without that threat of severe erectile dysfunction or severe urinary incontinence. And that's another 5 or 10 years of very good quality of life. But when it comes time, if it comes time to pursue those other options, the data shows that you can perform a prostatectomy after IRE, you can perform radiation after IRE, and it doesn't limit your options. So there are other treatments that can still be applied after a focal ablation. Next slide. This is looking at kind of 5-year follow-up for patients following IRE. And again, another thing to highlight, this is 8 years of retrospective data, right? So, IRE, even though it's new, it's got long-term results maybe not here in the US, but it does have that track record. And we're seeing, almost 70% progression-free survival at 8 years. And that's 70% of those patients, again, who can avoid the risks of incontinence and erectile dysfunction. All right, next slide. Some references for what we talked about. And just from a personal standpoint, the interest and passion that I've seen from patients in pursuing this technology kind of really reflects the lack we currently have for an intermediate option for intermediate risk prostate cancer patients, right? We're taking these intermediate risk patients and we're saying, we're going to treat you the same way that we're going to treat extremely high risk or we treat extremely low risk prostate cancer. And just, personally, if I had to undergo prostate cancer treatment for this type of disease, for your grade group 2, grade group 3 disease, this is what I would pick. And I suspect, many panelists, if you had a loved one, if you had a brother or a father who was looking down the barrel of the gun, metaphorically speaking, right, and had to pick a way to treat their prostate cancer, you wouldn't want some surgeon to take out the whole prostate or do radiation when this option exists for your intermediate risk. And with that, I'll conclude. And thank you everyone for your time.
Thank you, Dr. Song. That concludes our meeting. Thank you very much, panelists, for giving us your presentations, and you all have a wonderful day.
All right, thanks.